Waiting for the official go.
He's in London. He's gone to London. Ravi March.
Go ahead, Jude.
Go ahead, sir. We are live, sir.
Okay, thank you.
Good morning, good afternoon, and good evening, wherever you are in the world. My name is Dale Gardner. I'm an intensive care doctor in Nottingham, the United Kingdom, and I'm a board member of the Faculty of Intensive Care Medicine. It's my great pleasure to welcome you to this remote critical care symposium, a very big global perspective on this interesting and developing topic. Now, the practice of remote critical care has grown in different parts of the world as a solution to the many local issues. For example, staff shortages, lack of specialists in the area, the travel distance between ICU facilities. And after the experience of the pandemic and the growth in virtual working, it's really clear to all of us that remote critical care will grow even more in these countries. And this is our future we have to build together. So we are, the speakers, the hosts, are very grateful for the partnership between the Apollo Centre for Excellence in Critical Care, the College of Intensive Care Medicine in Australia and New Zealand, and the Faculty of Intensive Care Medicine in the UK. And our ambition today is very clear. It is a step to sharing and developing international best practice in remote critical care. So we hope that this is that step to future developments. What you're going to see over the next 2.5 hours is we're going to lay down the background content. We are very aware of the time difference challenges we have. And some of us are very late in the evening, and some of us are very early in the morning. And a long day conference, which we would host in previous decades, isn't going to be as possible. So what we're going to do is just in this very short time is have a number of excellent speakers who are going to bring the information to you. And we're hoping people who are here today will listen to that, but also in catch up and sharing afterwards. And this will be sort of the backbone of the future steps that people can go back to that content. Now, we are live streaming, as many of you are aware, on YouTube. And in the comments section on YouTube, please put in any questions and answers for the panel discussion that we will have later on. There is a comfort break built into the symposium because it's a 2.5-hour session, and we know that will be necessary. But without further ado, I want to just very honored to welcome Dr. Reddy, the founder and chairman of the Apollo Hospitals in India. He's going to give us the welcome address, but the Apollo Hospitals was established in 1983. It's definitely a leader in corporate and public healthcare in India, running over 75 hospitals. And I'm very excited they're actually extending beyond India's borders, and others of us are benefiting from their expertise. And they've been the real driving force for this symposium. So, Dr. Reddy, I'm very honored that you're going to give us your welcome today.
Thank you, Dale. Good morning, afternoon, and good evening to all of you. It's a very wonderful thing that we're meeting, especially after experiencing the importance of critical care during healthcare crisis, which in our lifetimes we have never seen anything like it of COVID. And the critical care units across the world, the teams did a great job. But I think what we are now trying to do through Apollo Centers of Excellence in Critical Care, thanks to Professor Mahajan, supported by both Ramakrishnan and Harnath, and the international faculty, that is very important, both from UK, US, as well as Australia. I hope more countries will join. We'll see the great effectiveness of a good critical care facility available for people at the time of crisis. Almost every second, we're probably seeing thousands of people across the world who need this critical care, and which will make a difference in their course of their illness. I think this is very, very important to realize that critical care probably plays the greatest role than even a heart transplant, because this is where a good care and a good team with all the backup support that we have, and especially using the new thing that this decade has provided, artificial intelligence, digitization. Using these, I think, we can make a significant impact in transforming the care and taking it to people across to the last mile. I know it's a dream. If I say to take the care to the last mile, to take it to the remote area, is not going to be easy. But I think what made it possible is the technology. The technology is available, and the willingness of all of you, the specialists in critical care, has made a very significant impact. And I must thank Professor Mahajan, who brought all these teams together to say, yes, we are ready now to that intensive care unit anywhere in the world. We'll have great standards and give precise care and practice precision medicine delivery in the critical care unit. But these two things are important. Number one, you need a team of the clinical expertise, but you need also a supportive team plus the technology. All the three are equally important. But to get all of this together, I think you need good training. This is where the attempt by Apollo Excellence in Critical Care is to bring all these elements together so that people everywhere could get excellent at the time when they need it. Nobody knows. As I said, every minute or every second, thousands of people are needing critical care across the world. So what we are now attempting, I want to give our full support, because in Apollo, already Professor Mahajan, Arnath and Ramakrishnan, they have done a great job bringing our 75 hospitals together, not only to give excellent care in our hospital, but they have also associated themselves with other hospitals which can have an access to us through telemedicine, and train them, train the doctor, train the technology, so that they could give excellent care with advice from our specialists. I think it then becomes a universal phenomenon. This is the only way we can reach the last mile. And I don't know how many times you need to multiply, how many more centers that we need to start, but I know for sure, but we make a good attempt, we will achieve it. Because this is what healthcare has always done. Nobody has ever thought that we will face this COVID crisis, I would say, reasonably well across the world because of the team. When the people are parent in their homes, the critical care doctors, the various specialists who are in their wards, who are in the critical care ward, and made a significant impact on a lot of people and brought down the significant mortality rates in the first, second wave especially. So I think it's a very wonderful thing that to have this symposium on critical care and have participation from across the world and make many centers participate in it so that they learn, they get trained, and they will be able to give this care for people. Because it's not possible. Even in city, there's one hospital. How many people can go there? So what we need is we need to spread this to as many hospitals as possible. To spread this, I think that two things are very important. The technology is important. The second most important is the knowledge improvement by training, both the clinical team as well as the paramedical supportive team. All are important. So I must congratulate each one of you. But I have my special thanks to the international faculty from UK, US, and Australia. So I hope many countries will join this. Thank you. Thank you for doing all of this. All that I can say from Apollo is we started from the scratch, but we know now that we can make a significant impact if all of us put our resources together. This is what I think Professor Mahajan and all of you have decided today to bring this symposium so that we can attract more and more people, give them the awareness that critical care can make a difference, and they can have critical care in their own setup. And then you will be able to support them through the telemedicine as well. I have no ordinary words there to say. A big congratulations for a big effort that you have attempted. Because always, in healthcare, we always say, we thank God and say thank God for helping us, that individual who needed the greatest care. And as I said, in all our hospitals, we see people who come to us with critically ill and go back smiling. So I hope this is what you create, an atmosphere where you bring in facility, the training, and the setup, and the tele-advice for various centers, so that world will be a better place for healthcare. So we'll make people healthy and happy. We can't give always life back, but definitely I think we're in the business of making health and happiness. God bless all of you. Again, my heartiest congratulations for the entire teams from across the world. God bless all of you. We are with you all the time. God bless.
Thank you very much, Dr. Reddy, for that welcome. Healthy and happy, that's exactly what we hope for ourselves, but also for all our patients. So thank you gratefully for that welcome to launch our symposium. So the first part of the symposium, we're going to be hearing perspectives from India, and then we're going to move around the world to Australia, New Zealand, the USA, and the UK. But our first speaker today is Dr. Sai Haranth. He's a senior consultant in critical care at the Apollo hospitals in Hyderabad in India. Now, his hospital is a hub for EICU for the Apollo network, and Dr. Haranth is a pioneer for starting some of this e-health work for critical care. So he's going to be sharing the current status of remote critical care in India. So over to you, Dr. Haranth.
Thank you very much, Dale. Thank you, Chairman and Dr. Ravi, for excellent introductions and for truly continuing to inspire us. I'm going to try to share my slides. I'm going to give you a very quick overview on what we've been doing and kind of segue into what's going to happen. And Dr. Ram will give us a little more perspective of what's coming down the line. So right now, I'm located at the hospital, I'm not in the hub, but I'll be showing you a very quick video, and hopefully we'll be able to see a quick view of what we're actually doing. And again, thank you again for organizing this conference, Dr. Ravi, and we're really looking forward to learning a lot today. So I'm going to try to share my slides, and really quick, just want to confirm that those are visible.
Looking perfect.
Perfect, great. So, this slide is a kind of a melange of the COVID virus and then how COVID really transformed how care is provided. You can actually see that we've had the ability to really deliver care anywhere in the world at the touch of a button. And we always knew we could do it. Apollo has always been a leader in this, but we realized that the scale and scope was just waiting for a catalyst, and the COVID virus was that. Now, in the last few years, we started the e-access program, which is the Apollo Remote Critical Care program, about 7-8 years now. And COVID really boosted our work. And we've done multiple presentations. We've had various discussions around the world on how we're actually doing it. And the biggest learning was that people are very eager to use critical care remotely. And myself and actually Dr. Ram both do remote critical care for the US. And with Chairman's blessings and his inspiration, we actually have started doing this for India several years ago. And we've learned that there are some subtle differences in how this care is delivered. And in a very practical way, I'll try to share some of the things that we do. Now, when we look at any program, this is a wonderful photograph, which I'm sure many of you have seen. And honestly, they are the inspiration behind this program, because this kind of a program needs a champion. And Chairman and his family has been, and Dr. Sangeeta and the rest of the crew have been champions for this, because you need to pioneer this concept. The way I put it forward to a lot of people is you're trying to sell telephones to people who never had phones, but you're giving them iPhones right off the bat. You're not giving them a dial phone, you're giving them an iPhone right off the bat. And Tele-ICU is a technology of that nature where the power is immense. And unless you know how to use it, you may not be using the entire capacity of it. Now, the hospital system here at Apollo has permitted innovation. They have given us room to grow, to test out new ideas, reach out to areas which never had even basic critical care. And of course, the cost of this has been subsidized by the institution. And this is something that is very important in a program where we've never really had a business model for this. And one of the arguments many people say for critical care given remotely is, where is the business model? Where is the ROI? But this institution has supported us in growth so that we can actually prove that telehealth and telecritical care is a viable proposition. Let's take the case of Mrs. Patel. She lives about, say, 50 minutes away or half an hour away from Hyderabad city. She's a housewife. She suddenly has shortness of breath, has a low blood pressure, is taken to the nearest hospital. They initiate emergency measures. This small hospital may or may not have the capacity to handle her illness, but they have to make a decision whether they want to treat her there, they're going to shift her. What are the other options? Let's take another place, perhaps right in the middle of London, perhaps near the NHS Confederation. And Mrs. Mason has similar symptoms. She has a low blood pressure, chest pain, shortness of breath. She goes to the nearest hospital. What is the care that can be delivered? Let's frame these two patients in our mind as we go through this talk. When you have somebody with critical illness, you're moving from health to critical illness, you actually need an expert to diagnose this, but the expert really depends on evidence, data, and he needs to communicate this entire infrastructure to figure out what is the actual critically ill problem. So either Mrs. Patel or Mrs. Mason, you're trying to figure out, does she have congestive heart failure? Does she have a heart attack? And what is the data to support it? Now, if you frame this, now all of this can be done remotely. Most of this is cognitive. The data can be shared and evaluated remotely. What you really need, though, is somebody at the other end who can do a basic examination to understand what is the actual presentation of the patient. The history can be taken remotely. You can even examine remotely now. But at the same time, you want to make sure that all of this data is synthesized. And telecritical care completely depends on the communication angle between the patient, the remote provider, as well as the bedside provider. Now, you can do monitoring, video communication, triage. And in India, since 2020, once the telemedicine practice guidelines came out, it became much easier to actually do this in a very structured format. The evolving things which we are using in our system includes wearables, remote devices for capturing vital signs, video and phone communication to assess the state of illness. And of course, to decide in the COVID pandemic, we were using this to decide if patients needed oxygen alone or do they needed more advanced support. We also wanted to make sure they were safe to transfer the higher levels of care. And if there were no beds available, we would assist these hospitals in managing them in a remote site. One of the biggest things we did was education of the patient, the remote team. And we still do this, where education of the entire bedside care team in escalating their expertise is something that has been found to be very useful, especially in advanced support like mechanical ventilation. In fact, we've done courses to actually teach mechanical ventilation in a remote fashion. Now, the Indian ICU, as you know, has multiple challenges and opportunities. Now, the challenges, as we know, are probably largely because of a demand-supply gap. We have a lot of issues with quality issues. We have issues with accessibility, availability, and some of these have been solved by the Indian Society of Critical Care Medicine. We also have multiple subspecialty units, including all-purpose ICUs, tropical disease ICUs. We have tropical diseases, seasonal diseases, disasters, including epidemics, and all of these absolutely kind of impact how care is delivered. Now, the skilled workforce gap that is there, if you really look at it, in fact, I like to learn something new every time I give a talk. And I figured out that the World Bank actually has a way for you to generate your own graphs of whatever data you're looking for. So the bottom left, you actually see a graph of what is the number of doctors per 1,000. And you can see that in India, this has been improving. It is not yet at the WHO standard, but it has been improving. You can see that the Middle East has the single point dots that you see. They're actually at a higher level right now. And there are some parts of Africa which are still on the lower side. So it's interesting to note that we still have a huge gap. We need a lot of doctors, and critical care needs are also important. And one of our colleagues from the Chennai Apollo team has actually published this, and he talked about the number of beds that are available, the number of ventilators that are available, and the numbers are still not very large for a country of 1.3 billion. Now, remote critical care at Apollo is, of course, anywhere, anytime. We have a team that is sitting 24/7. We are using technology to monitor, and of course, people come first. And this ensures equity because, as you will see, we are having patients in multiple locations where they're unable to actually come to the hospital in any form or fashion, but we're able to give them even very advanced care. Now, our response to COVID you may have heard about, this is a little older slide from a few months ago, but we have had, the numbers are in magnitudes of thousands. The numbers of people treated, the numbers of people cared for in COVID centers, the number of medications dispensed, and critical care alone, we have done over 15,000 patients have been managed just for COVID care. Our group at a glance includes over 70 hospitals, 10,000 beds, and these numbers are continuously increasing, and a large amount of that is because of the inspiration and support from the organization. We have touched several 100 million lives, and if you look at critical care alone, the dollar value for that because of the remote care is huge. In the COVID pandemic, we were swimming despite the waves. We had a lot of knowledge transfer. We, in fact, had home-based diagnostics. We had home care coordinating with us. We were actually managing ECMO triage. We also partnered with a UK-based hospital expert to mentor our own ECMO patients, where essentially he was in our ICU, remotely guiding us, saying, hey, this is what you need to do the pump, adjust the settings. And we had very specific advice given. And post-COVID services has now increased quite a bit. Interestingly, we had several thousand non-COVID subspecialty consultations that also came up, where we were actually guiding patients who required non-COVID internal medicine or surgical or trauma-related advice. Now, we are a large system. We have several experts, many of them trained around the world. And we actually put a group together, and this is the 51st edition of our COVID protocol. Interestingly, it went through, obviously, as all of you would know, multiple iterations, and it's simplified so much so now that basic care, we know, actually works. And we actually were able to share this protocol with hospitals around the country, where they were able to actually follow the advice that we were following in our own hospital. And this was a huge benefit for many places which were very confused as to what to do. But once they knew that even a large system like ours was following the basics of care, most of them were reassured and most patients did well. And we were monitoring these patients on a continuous basis using our e-access services. This is a snapshot of what it would look like in the EICU at the bottom, where we can see the patient, we can see their cardiac rhythms, and we can also see the data that comes through. We also published AI-based detection of our clinical patterns, looking at a mortality risk prediction using the data from the COVID patients. In addition to that, we have published in multiple places. WHO actually pulled one of our articles to actually use it as a kind of a case study on how we can use tele-ICU during the pandemic. They've also estimated the savings for patient resources just by the fact that, for example, if you take in India, a patient comes from a village, say 200 kilometers away to the city. Not just him, the patient's wife, child, brother, uncle, everybody has to come. And that's going to impact education, livelihoods, extra costs of boarding and lodging, and all of these costs can be eliminated if the patient is retained in the remote site. And this is an area where I'm hoping economic professors and experts will analyze more, because this is an ancillary benefit no one's really looked at in detail. Because if you really look at it, most care can be given in a remote site. 80% of care can be given in a remote site is my estimate. We have also published very specifically on neurointensive care, and where we have looked at our patients and decided that stroke care, either bleeding or strokes from ischemia. We've also looked at trauma-related neurologic emergencies. We have helped guide patients. And we've also helped patients who require assistance with ventilator management, especially after a neurologic event. We also published during the COVID crisis a kind of an overview of what we could do for a tele-intensive care unit network. And we've kind of shared this in many other fora. Now, tele-ICU is very similar to how aviation should be, where we have a safety network where all of the information is monitored, all of the information is analyzed while simultaneously delivering care. We have the benefit and the luxury of sitting away from the patient bedside, so we can very objectively look at all of the information in a very composed and rational way. One of our colleagues in our hospital system, Dr. Ganapati, always says, telemedicine has created this analogy where geography is now history, because truly speaking, you can deliver care anywhere that is required. A quick video here, I'm hoping it plays, okay. The audio may or may not be visible, but this is a quick show of how our patients look. This is our command center. We have doctors sitting and monitoring patients. You can actually zoom right up to a ventilator. and you can analyze a ventilator. If you can actually teach the nurse there how to use the settings on the ventilator if you want certain parameters. We do know that in ARDS, respiratory distress syndrome, you need to adjust the ventilator for a low tidal volume. And despite all the advances in care, this is a metric that is not universal yet. And we were able to actually achieve this by teaching nurses and doctors on the job. We also get multiple alerts, which we can address on an ongoing basis. Another video, which I'm going to show you right now, is a doctor who is guiding a remote ultrasound to kind of teach them as to what an echocardiogram should be done and how it should be done, and kind of get an assessment of the inferior vena cava, look at the left ventricle, and all done remotely, and the patient is far away. There have been studies which have come out in the last year which have actually shown that you can train lay providers to hold a probe and actually teach them. And this is just an example to show you how you can actually deliver the entire spectrum of care on how this should be done. And this is just a listing of what the benefits of tele-ICU are, and you can take advantage of time differences. For example, right now, I'm going to in fact challenge the team here from Australia, New Zealand, and England and say, why can't people from other countries deliver care? We do it for the US, we actually do it for the United States, but Europe and Australia have been a little slower to implement this, although I see a huge demand for something of this sort. And I'm hoping a conference like this can bring up these conversations so that the regulatory barriers that are there can be overcome. So really speaking, can the world adopt telecritical care? So the NHS, Australia, New Zealand, can you adopt cross-border telecritical care? Is that even a possibility? Now, all of this depends on three basic tenets. One of them is value. Are you actually delivering better outcomes, better health? Is the cost lower? Does the system trust you? In other words, you're a doctor sitting really far away, you're a nurse sitting far away. What is the trust that is there between a remote team and the bedside team? How do we overcome the risks, which may be the barriers, and how do you build a bridge across it? And what is it that is going to determine the faith that will give you the ability to carry this forward? Is there reputation? Is it quality? And what are the deliverables? Now, these are the things we should debate and structure better. The Chest Journal had come out several years ago with an article on research in telecritical care. How do you actually structure it? How do you do it? And there have been multiple articles who talked about the economic value, the human resource benefits because of the gap between provider availability and the actual bedside lack of providers. And nothing has really proven 100% that this makes a difference. But if I look at the anecdotes of care, where I know that we have made a difference, and Dr. Ram and myself have done this around the world, and you can actually see that each patient that you save makes a huge difference, and you can actually deliver care on the spot and also teach the team. 800,000 people die every year because of this one little insect. This arthropod takes a lot of lives, and anything we talk about now doesn't weigh in a balance in terms of the destruction done by something like this. So when people question me, why are you investing in technology? I say, absolutely, you need to do both. You need public health, but public health delivered with the help of technology makes a huge difference. Think about all the number of patients with dengue shock syndrome or septic shock and malaria, which you can actually manage remotely just using remote care. I'm sure you've all heard about team, together everyone achieves more, but I truly believe together everyone achieves miracles. And telecritical care, I'm an evangelist for it, I really love it, but I think you can actually achieve miracles. You're delivering care to the furthest of the furthest locations, to people who have zero access to the expertise that you can deliver. You teach them simple things: septic shock, give IV fluids; ventilators, adjust the tidal volume, adjust the PEEP, do proning, give antibiotics early. None of these are super complex. But if you can do this consistently and teach people this consistently, you can make a huge difference. So I'm going to stop there. I might have gone a little over time, so my apologies for that. But I think we should be able to have a great discussion on the segue between India and the rest of the world in delivering telecritical care. Thank you all for your attention.
Thank you very much, Dr. Haranath. I really like that theme. I think you've given us the theme for the symposium is geography history. And I think that's a really sort of great one. And also emphasizing doing the basics well. We're going to go straight over to Dr. Ramakrishnan Nagarajan, who's a senior consultant in critical care at the Apollo Hospitals in Chennai. He heads the unit. Got extensive experience, especially giving consultations over tele-ICU in India and, as we've just heard, outside, and going to give us current developments in India and what we can look forward to. So thank you very much for presenting.
Thank you, Ravi, for the invitation, and thanks to Apollo Hospital for this great initiative to collaborate internationally. I just want to make sure my slides are opening. Is that okay?
That's perfect. You're away.
Great. Okay. So what I wanted to focus on in the next 8 to 10 minutes is reality and challenges that we actually have with telecritical care or remote critical care. There are different terms that are used. Really, what we are trying to do is close monitoring from a distance. I would like to start out with how telecritical care evolved, particularly in the US, how we got involved almost 12 years back, and talk a little bit about how it worked in the global scenario, what are the real challenges we have in the Indian scenario. Obviously, not everything is rosy in any part of the world. So we will just talk about that and how critical care has existed, telecritical care has existed earlier, how it is evolving, and what is likely to be the future. And in particular, talk about some focus services. Sai Harnath had alluded into tele-neurology, telestroke services. We'll talk about a few more options that we could probably provide using telecritical care. Now, healthcare is very poor when it comes to safety, unfortunately, and it is thought to be one of the most hazardous things, probably close to bungee jumping and mountain climbing, as you can see here. And there has been a lot of work looking at safety in critical care. And the Institute of Medicine in the US published or looked at the medical errors in the US, which is thought to be one of the leading causes, not only of death, but also morbidity, including extension of hospital stays, delaying the recovery, additional treatment, permanent disabilities, and overall increasing the cost of care. So the Institute of Medicine in 1996 launched an effort where they wanted to focus on assessing and improving the quality of healthcare in the US and reducing the medical errors. So this report, titled appropriately as "To Err is Human," was created to build a safer healthcare system in the United States. And they came up with a goal of reducing the errors by at least 50% over the next 5 years. A very reasonable expectations, not to say that it's going to be 0 errors in 5 years, but trying to reduce the errors to at least by 50% over the next 5 years. Now, the moment this report came out, the first ones to jump on this were obviously the Fortune 500 companies, which were the largest payers for healthcare services in the United States, which, as we all know, is predominantly driven by third-party insurance. And of course, one of the third parties happens to be the government through the Medicare. But the Fortune 500 companies said, why are we paying so much for care that is probably not of the highest quality, and there are significant errors? So they wanted to establish purchasing strategies based on overall value of the service that is provided. And they wanted to also come up with what could potentially be process improvements that can reduce the medical mistakes. Now, in case you're wondering why I'm going into this, this is how telecritical care actually evolved in the US, because the Leapfrog group, which the Fortune 500 companies put together, came up with this report, which reads several pages long. But to summarize it, they came up with the top 3 things that could make an impact on reducing the errors in healthcare. And the number 1 thing was computerized physician order entry. As we all know, doctors have a great handwriting, half of which is illegible, half is being an underestimate. So they said that if we could directly enter the orders, whether it goes to the pharmacy or to the lab or for the nurse to interpret, if it is directly entered, the chances of errors are much lesser because it is going through multiple layers. It avoids going through multiple layers. The second was evidence-based hospital referrals, where data now starts existing on the outcomes of common procedures, like common aspects that we deal with in critical care or anywhere. And they wanted to go by outcomes and said, if we could refer patients to hospitals that have shown that their quality of care is good, then we would probably feel much more safer. And if such data does not exist, then guidance would go by large volume hospitals that are likely to have also probably better experience and outcomes. The number 3 thing that they listed, and that's the reason that I started with this, is ICU physician staffing. It was clearly shown through this group that having ICU physicians dedicated for managing patients in critical care would make a difference to the outcome and reducing the medical errors in the hospital. Now, having said that, it's not easy. So they said that we do not have enough critical care physicians to be managing around the clock at all hospitals in the United States. And therefore, they came up with this option of, if we can have intensivists, critical care physicians present during the daytime hours, provide care exclusively in the ICU while they are there. So for those of us who may be internists or pulmonologists or anesthesiologists, the time that you are dedicating to critical care, not to be shuttling between your other commitments, but to dedicate your services to the critical care. And at other times, if we can have intensivists who can return ICU calls promptly and rely on whom they called certified effectors to implement the telephonic orders. So by this, there was also the Society of Critical Care Medicine started this fundamental critical care support course where they started training several doctors and nurses who could understand the lingo of the intensivist so that they could appropriately implement the orders that were given. Now, this was probably the lead to telecritical care because clearly there was a shortage of intensivists, there was reduced access to specialized care for the critically ill patients. The care gap was much wider during the night times and weekends. And as we already said, if we don't have trained physicians, trained intensivists, there could be a lot more medication errors and case management slips. And this could negatively impact the quality of care of patients as well as the performance of the hospitals. And therefore, it was felt that they needed to come up with innovative solutions. And that's how technology was brought in and telecritical care came in. So the intensivist shortage was significant and coverage was essential based on the Leapfrog Group recommendation. And in a country that's predominantly driven by third-party insurance, it was kind of almost necessary for them to quickly come up with a solution. And that's how telecritical care was widely adopted. And just to briefly tell how we started doing the services, obviously there weren't enough physicians, enough intensivists in the US to be manning round the clock. And they looked at the American Board of Internal Medicine, looked at trained intensivists who are no longer in the US, and they found that India had several board certified physicians. They narrowed down to which city had most of the board certified intensivists. And that's how we were contacted in Chennai. And we started the first telecritical care services anywhere outside the US, which was the first one to start almost 12 years back. So since 2010, we have been providing critical care services to the United States. Now, sounds great, sounds nice, but when we were trying to implement it in India, really, distance is not the real barrier because we are able to provide it several thousands of miles away. But when we tried to do it for India, we had our own challenges because the urban and the semi-urban hospitals had different kind of requirements. The rural centers had different kind of requirements. So there was a lot of customization that was required, and I will talk a little bit more about this. The critical care issues that we have in India are lack of standards, laws, and specific regulation. ICU care is not necessarily specialist driven at several hospitals in rural India, particularly what we call nursing homes, not the nursing home of the US or the UK, but the smaller, what we call access hospitals, some of which are private. And those hospitals have different kind of requirements and want to retain patients, as Sai Harnath said. So that's what they were looking for, to have care so that they could retain the hospital and patients there. There's a lack of grading of ICUs in critical care. I mean, patients who require level 3 care could end up in a small critical care unit in remote part of the country and still would try to be managed there. So having tiers, having levels of care was not appropriately done. And as Dr. Harnath already mentioned, the number of ICU beds available is disproportionately low considering the population. This was our own publications in the critical care clinic, where we looked at outcomes of telemedicine in critical care. And we found that even in the US, when we looked at the literature that was available, the impact of tele-ICU on ICU and hospital length of stay and mortality was variable, looking at, depending on which study you look at. And although tele-ICU implementation can incur substantial costs, particularly if we go with the US model where we have a large hub or a monitoring center or a command center and the spokes, it will be cost effective only if the intensity of the application is high. They had the proactive model where we were constantly monitoring the patients 24/7, identifying issues earlier, talking to the units, a lot more intense system, which obviously is not practical or was not doable here in India. I just wanted to compare what kind of differences that we observed. Number one was the technology penetration. In the US, even in smaller reach hospitals or access hospitals, the technological penetration was high. A lot of them had electronic medical records. We could access directly. We could be placing orders directly, whereas that was low to medium levels in India, depending on which hospital we were trying to provide service. Definition of the tasks, roles, and responsibilities, obviously a lot more well-defined, documented in some of the Western countries, not as defined here. Again, nurses' caliber could be variable, very variable depending on the hospitals that we are dealing with. Respiratory therapists do not exist in a lot of the hospitals. So we had to kind of do a lot of training, which, as Sai mentioned, was also becoming integrated into the telecritical care component. Human interface was much lesser in the US, thanks to the technology penetration, whereas here, a lot of paper data existed. Even for accessing images, sometimes we had to, zoom in and look at the X-rays directly rather than, access through the web. So the proactive model was what was used in the US, but as I mentioned, in India, the need was different. Some of them wanted reactive, some of them just wanted specialty consultations. And it was not felt as a required service, and the acceptance was kind of variable depending on where we wanted to. This is not my own, but I just felt that this is a good way to look at leveraging the care delivery model by using, number one, the computer intelligence, getting the data, looking at benchmarks, big data handling capabilities. How can we use artificial intelligence? That would be the first layer, followed by critical care nurses. And I would also add some other support professionals like respiratory therapists and physician assistants who could triage the care. And then finally, the intensivists focusing on the overall patient care and the clinical intervention as appropriate. So this would obviously be a much better usage of the services of each one of these groups. Now, there are a lot of other telehealth opportunities. And in fact, during the COVID, we had specific requirements for just COVID care, sometimes even over the video call over a telephone. So that was, in a way, a different style of telehealth, that telecritical care that we could do here in India. There are a lot of specialist consultations that are required in the ICU, nutrition support, pharmacy. All of those are probably focus uses that we should probably think about, which are very much required. Telestroke was already addressed. Tele-CPR is an option. Ventilator rounds, some hospitals want support just for managing patients who are on ventilator, getting second opinions from not only intensivists, but other specialists as well, doing antibiotic rounds, doing nutrition rounds, having a qualified critical care nutrition support team would make a difference. And not to forget tele-rehab, home ICU, but particularly post-ICU care. And I already mentioned about COVID care. So really, the time is now for us to move to technology and telecritical care. But how we are going to do that is something that all of us can discuss. Thank you.
Thank you very much, Dr. Nagarajan, for that talk. I liked what you talked about leapfrogging, and it just made me feel sad that 20 years ago, I left my Australian intensive care with e-prescribing and a computer at every bedside. And 20 years later in my intensive care in Nottingham, I still don't even have that. So I think I've seen the future, and you've already got it, and you might call it your past, but for me, it's still my future. But to hear more about it, in the interest of time, I'm going to go straight to Dr. Danny Bryden, who's the Vice Dean of the Faculty of Intensive Care Medicine in the UK. And she's going to give us a wider perspective on the UK and also a bit of a gap analysis of where things need to go. Over to you, Danny. Thank you very much.
Thank you, Dale, and thank you very much to colleagues for inviting the faculty to take part in this meeting. I'm going to go straight to the issues for us in the UK. So we are known notoriously to be a very densely populated country. We've got the 4th highest population density in Europe. But when you actually look at this heat map, and as you can see, the areas in red are where there is the highest population of our nations. We've got huge swathes of the land mass that are very sparsely populated. So we don't have a consistency of healthcare provision around the UK. And this has been known about for a long time. The Marmot review that actually reported in 2010 indicated that there are huge groups in our society who spend long periods of their life in ill health. And it's not just related to their ethnicity and socioeconomic status, but these people on the whole have an average of die 7 years earlier than the rest of the UK population, and probably have another 10 years before that where they are in poor health. Just around the time of the pandemic, the Chief Medical Officer, Chris Whitty, released a report looking at where those issues are. And as you can see here, the areas that are in red relate to the areas where there are poor ill health and access to health services. And that's really around the coastal communities. So in the UK, we have a situation where people are living in our cities, where all the resources concentrated, but large chunks of the population are on the coastal communities and are not getting the same access to healthcare and have poorer health as a result. And those are the areas of the UK where we are struggling in terms of our healthcare provision. Often those areas may have limited job opportunities outside of the NHS, and it's very difficult to attract NHS staff because all the health and wealth is concentrated in the cities. So we know that we're not producing the right sort of healthcare stuff. And I'm just using this illustration of a report that was produced just at the start of the pandemic around medical stuff, but that same applies to many other healthcare groups, that we have gone down a route of super specialism, and we don't have healthcare workforce that is prepared to live in and work where the areas of need are, and want to specialise and want to be super specialist in our cities. And although we are going to try and socially engineer some aspects of that in terms of future training, there is an issue. The Faculty of Intensive Care Medicine has promoted the development of advanced critical care practitioners who are providing us a group of highly trained individual skills who don't come from a medical background, but have many medical skills, who are helping to meet some of these healthcare gaps in our units up and down the country. But again, the rollout of that new professional group has been patchy and has unfortunately still focused its development in the cities and around the cities. So when we, as the faculty, recognise that we're not producing the right sort of healthcare staff, we focused on collecting data. And we look at our workforce in terms of our survey that we do every year. And we've also conducted a number of local engagement events. So that's different parts of the UK going and having conversations with the people delivering intensive care medicine and trying to identify what the particular barriers and opportunities are for them in each of their areas. And I know I'll say no more because there'll be more discussed on that in a moment. So from the UK, our perspective really is that we don't have sufficient trained critical care staff across the board, both medical and nursing. They're concentrated in the cities, and yet our coastal and rural communities, we know, are already underserved, and we're struggling to provide the trained intensive care staff to deliver that additional care that they need. We know we have a healthcare system that needs generalists, and that probably includes general critical care skills, but we have a limited number of people who can deliver those skills. And the biggest issue for us, which I've not really touched on very much before now, is around the fact that we are a state-funded NHS system. So the focus has been on workforce. The focus post-COVID going forward is making sure that the procedural backlog, the backlog of elective surgery is a focus for healthcare going forward. But the kind of changes that we need to really deliver remote healthcare, particularly around technological developments, historically we've not really been able to achieve, as Dale mentioned, and going forward, we're going to struggle with that technology involved in investment, because again, it doesn't really appear in very many of the plans going forward, which are focused on sort of solid structures and perhaps adjusting some of the workforce. So I'll stop there with that introduction, and I'll just hand over to my colleague, Jack Parry-Jones. Now, Dr. Jack Parry-Jones works in Wales. He's also the chair of the faculty's Careers, Recruitment and Workforce Committee, and he's going to give some flesh to the bones of the introduction that I've just provided. So over to you, Jack.
Thank you very much, Danny. I hope my screen is sharing. Can I just confirm that?
Working perfectly, Jack.
Lovely. Thank you very much, Dale. Yeah, thank you very much for the invitation to speak at this. I have, over 10 years ago, we used to run an intensive care course, exam course, which we ran in India, and we ran several exam revision courses in Delhi and Mumbai. And I also have a family in India, in particular in Pune, Mumbai, and Nagpur, where my wife's family are from. So I'm very pleased to be able to sort of renew links with India. So as Danny alluded to or mentioned, the faculty have done workforce engagements, and we did 9 regional engagements across the UK. So we started in Wales and we finished in the south. The last one was in the south of England. And we ran those between 2015 and 2019. And in total, we did 9, but we did an overarching report in 2018, which is available on the faculty website. And at that time, this is obviously pre-COVID, that there was enthusiasm for teleworking, and there was enthusiasm for combining rotas, but the majority of people felt that this was not the workable solution, and it wasn't the solution to our major problems in the UK. Each region, so there were, I'll come to an ICNARC report later, but most of the regions that we were looking at aren't the ICNARC regions, but they're deaneries essentially. Most of the deaneries have the same issues. So they have big units and they have small units. And in each region, there were some units that were really struggling, and they struggle with low staffing. And when you have low staffing, it ends up in a vicious cycle where you can't recruit, you get poor morale, and you get worse staffing. And the key thing at that time in the UK was trying to improve those units in a downward spiral, I would say. Now, each region also has small hospitals and big hospitals within them. And in the GPICS reports, we have what are called small and remote units. And a small hospital is a hospital with a critical care service that covers a population of under 200,000. And it may seem strange in India or Australia in particular, and the States actually, that a remote unit for us, or a remote hospital, is one which is more than 30 kilometers from the next nearest emergency department. So we are a small country, we are densely populated, but that's how we define small and remote. So the critical care capacity in the UK is probably our biggest issue. And although it is a national health service, as Danny said, there are big differences. So there isn't standardization, and that critical care capacity is very variable across different areas. I put the links in there if people are interested for later to look at. So the major one is a report from the faculty called Critical Care Capacity, and then our workforce data bank illustrates the major problems in staffing, and that's in particular nurse staffing. And of course, in the UK at the moment, we have actually, I'm afraid, recruited a lot of nursing staff from India, and they will go back. And we also have many international medical graduates, and they will go back. So we are using other countries' staffing to help our own. But actually, when they go back, I think that will improve links in the future. And then the third thing on capacity there, I put it, is getting it right first time. So getting it right first time is a look at regional variation actually in critical care in the UK, and I'd highly recommend that report. So, and we have the Intensive Care National Audit and Research Centre, that's ICNARC, and this data actually is just pre-COVID, so there has been expansion in some critical care services due to COVID. There was the emergency response, which obviously in some cases doubled, tripled, or even quadrupled critical care capacity. But when you're looking at an ICNARC service, when you put your unit into ICNARC, you declare your bed numbers. And these are the declared bed numbers across the UK, minus Scotland. So there are 6 units in the ICNARC data set which have between 0 and 4 beds, staffed beds, and then there are 51 between 5 and 8. So in total, there are a quarter of units in the UK have fewer than 9 critical care beds. And then, I work in a big unit, it would be defined as a big unit, which is 35 critical care beds. Those numbers, the number of big units is actually small. And then this is also from an ICNARC report. So, and I put this because we're all still obviously geared towards COVID. This is an early COVID report. So this is up to 30th of June, 2020. And I put this here because it's a funnel plot, and it illustrates several points. The first is the number of units that have a few critical care admissions with COVID at that time. And there are others with over 200 COVID admissions. And then the orange dots at the bottom, there's an SMR there, so that's 1, the standardized mortality ratio of 1. Those best performing units are in orange, and you might say that those are the units that the other unit should be speaking to help them manage their COVID cases. Which I think was probably the case. There were certainly lessons that could be learned, and they could have been learned quicker with the use of telemedicine. I come back to the care capacity though, and this is also from an ICNARC report, and it illustrates the 9 different regions that were reported. And this is this is all the way through to 2022, it's April 2022. And by that time, all of the UK had multiple waves. So we would normally say probably 4 COVID waves. And the number of patients that you'd expect in each region would be the same. So this is cumulative number of patients per 100,000. So it accounts for density changes in the UK across the regions. And the important thing is, you wouldn't expect such a large regional variation, I don't think. So those lines should be much closer together if provision was more equitable across each region. So, and we know that London has a lot more critical care beds than the other regions. And actually, you can't go into an ICNARC data set until you're actually admitted to intensive care. So I think what this really demonstrates is that there are large regional variations in the ability to admit patients. And then there's the what kind of care is being delivered when you're within the regions. So intensive care. So we previously looked at and asked our workforce, what do you find intensive care medicine stressful enough to influence your future career plans? And if so, why? And the biggest issue, this is pre-COVID, for critical care consultants in the UK is inadequate trainee numbers, and then inadequate training of those people. And then lack of resources is the second biggest. So that's the ability to admit someone when someone is critically ill. And then right down at the bottom is inadequate IT support. And actually, I think COVID has really illustrated, and Dale mentioned this, is that actually IT, when we're talking about IT support in critical care in the UK, we're still talking about actually the ability to have integrated care systems at the bedside. That COVID has really illustrated that is much more important now to everybody. And I'm just going to look at this from a slightly different, well, the opposite way around, actually. So senior decision makers on site is the other end of telemedicine. So that is putting a consultant on the shop floor 24 hours a day. And resident on call, there are units that are running resident consultant on calls. I work in one of them. And the reason for that is really because there is concern about the training and the number of trainees that we can employ, actually. Most units now, bigger units, are consultants are resident up until 10, and then there are just those 2 really big university, and then third now is on board where they've got resident consultants. And I put a reference there to a paper that was written about resident intensivists. And actually the outcome of that paper, that review really is that if you've got senior trainees or very senior trainee intensivists on site, you don't need a consultant resident. So remote working or telemedicine, what problems are we actually trying to solve? So on-call out-of-hours cover, yes, one intensivist could cover multiple units, and that's it. We know that that's possible. We don't do it in the UK at the moment. Do we want an expert opinion? So that's a SARF, I put, so severe acute respiratory failure units in an ECMO model, access to MDT expertise. Yes, the ECMO referral model in the UK does that to some extent. It could be elaborated. Do we want rapid access to an expert panel? That is possible too. We don't do it yet, but that's really around ethical dilemmas. It's certainly possible. I think that will be coming more. Do we want a network regional solution for non-ICM trained consultants covering care, a hub and spoke model, which has been spoken about? Yes, but I come back to actually what Dr. Harananth said about value, trust, and faith. And I think there's a lot of work needs to be done on those 3 key areas and which will enable a hub and spoke model to work better. And then in the UK and all developed countries, in terms of the emphasis of care now is on sort of centralized access to acute critical care in large units. So those are your trauma centers, your out of hospital cardiac arrest centers, your CAR-T and other immunotherapies, and the support with critical care, stroke medicine. So the trend is for the care needed to be done acutely in those centers, but actually critical care units are still needed in smaller units where you repatriate the patient from the acute big centers into smaller centers for care closer to home. So drivers really from a remote care. I've put in the UK. So for the UK, I think there are too few intensivists. So that's a driver for it. Financial in the UK, there isn't a financial driver that's as big as it might be in other countries, I think would be fair to say. And actually the remote units and the remote hospitals, there's a financial incentive also to keep them there. There is a driver. I think we could provide better critical care with appropriate referrals. There's an issue around carbon footprint and sustainability. that we should be doing fewer transfers if possible. So that's a driver to keep people where they are with appropriate support. And then the system doesn't work. Well, the system does work, but it could work a lot better, and we need to change that. And I think COVID has illustrated that. And then the obstacles, well, the biggest obstacles are around, as I said, admitting capacity. It's very difficult to solve admitting and understand capacity unless you actually work in that hospital. IT support is a big problem. You can't share data easily between hospitals at the moment. There are medical legal obstacles to overcome. At times, we still need on-site consultant presence. So how would you resolve that? There's our dependent specialties. So, for example, cardiology, gastroenterology, hematology. How keen would they be for the critical care opinion to be delivered from a remote site? And then the status quo. Well, the status quo is for everything to stay the same, and I think we should never underestimate the power of the status quo in doing that. So in conclusion, we have large regional variations in the UK in staff critical care capacity. Our regions do share many of the same issues. That's big versus small, urban versus remote. I think COVID has illustrated what we've known in intensive care for a long time, but COVID has illustrated to those areas outside, managerial areas outside of critical care, what our problems are. So I think that gives us a big ability to change things. I think before COVID, many ICM consultants didn't see IT solutions as the key issue, but I think that has changed. And I think that there is a much bigger appetite for this now. In the UK, we do need to do a lot around improving our capacity and improving our patient informatics systems. We do need to do more work on our networking, so within regions. We need better critical care transfer services. They are improving, and COVID has illustrated that, but that needs to be better understood and worked between centres, acute centres, big centres, and the smaller, more remote services. And then we need better communications between the two. And as I've said, I think COVID has given us actually illustrated our problems, and it does provide a much better idea that we can and need to change things for the better. And I think remote critical care is one part of that solution. Thank you very much.
Thank you very much, Jack. I think you really sort of struck home that point about the status quo and how COVID has just broken that, and we're all looking for new solutions. And I also think that data you shared was, just excellent. Sort of, we're very good in the UK of measuring things, even sometimes if just to show how bad things are. But we're going to go. I'm going to take chair's prerogative. We're not going to go to our break immediately yet. We're going to delay that for a moment, and we want to go actually to Australia and New Zealand. I'm going to hear from Dr. Mary Pinder, who's the president of the College of Intensive Care Medicine in Australia and New Zealand. Now, as we know, in those countries, they have geographical challenges, low population density, but also very much known for their advanced intensive care medicine services and the use of technology. So we're going to hear from Dr. Pinder. Thank you very much, Mary.
Thank you, Dale. And thank you, Dale and Ravi, for the invitation to speak on behalf of the college, and to the Apollo Centre for Excellence in Critical Care for being the driving force behind this fascinating and very important webinar. I would just like to begin by saying the College of Intensive Care Medicine acknowledges and pays respects to the traditional custodians of the lands across Australia on which our members live and work, and to their elders past, present and emerging. As a binational college, we also acknowledge and respect Māori as tangata whenua and Te Tiriti o Waitangi partners in Aotearoa, New Zealand. I also give my respects to all First Nations people who may be taking part or viewing this webinar. Kaya, kena toto, and greetings to you all. So remote critical care from the perspective of Australia and Aotearoa, New Zealand. We certainly have a lot of the issues and challenges that have been discussed already from the perspective of India and the UK, although the economies of scale may be a little bit different. As Dale has just mentioned, Australia has problems with the tyranny of distance. And I'll say for my home state of Western Australia, we have a landmass of, I think, about 2.5 million square kilometres, with a population that is now about 2.8 million people. So we have almost a square kilometre each. And over 2 million of that population is actually centred in the capital city in Perth. So I think we have sort of bigger problems than a remote definition of being more than 30 kilometres from a major centre. In terms of Aotearoa, New Zealand, the use of telehealth is not so well established perhaps as it might be in Australia. And this is information from my colleagues across the Tasman. So apologies if I'm speaking out of turn. But for any of you who've seen the Lord of the Rings movies will know that the geography in Aotearoa is unique and situated there in the South Pacific and being long and narrow, but with rugged mountain ranges, tortuous rural roads, and what can be a very dramatic climate that predisposes to weather conditions that may be unflyable, and also earthquakes and volcanic activity. So certainly over the last 10 years, telecritical care has been much utilised in Aotearoa for mass casualty events such as earthquakes, volcanic eruptions, mass shootings. They've suffered quite a bit in recent times. But also it's been identified that this could be, again, a way of improving workforce shortages and issues, and a potential solution to workforce and infrastructure disparity between metropolitan and rural centres. In Australia, remote critical care has a significant role where you have obviously relatively small populations concentrated in major cities with resources following the population distribution, just as Danny has spoken about in the UK. My colleague Brad Wybrow will be giving a presentation after me, and this will talk about an example of telecritical care based in Western Australia. So a lot of the situation, as I've said, is similar to that experienced in other countries. And certainly the challenges for us in Australia are considerable and often relate to funding and setting up programs that may cross jurisdictions. So, funding for establishing and maintaining services requires interjurisdictional collaboration and agreements that then involves a sort of murky world of health economics, and even murkier one of sort of state and federal politics that can be a problem. And having appropriate technology is also an issue. And although I think we forget that remote critical care can be as simple as using a mobile phone. Obviously, having the sort of technology that has Sai spoke about in Chennai takes things to another level. But again, in Australia, we have areas where there's no mobile phone coverage and internet access is patchy with slow speeds and limited bandwidth. Another challenge is having staff who are appropriately trained. So they need to have recognised qualifications for the jurisdiction in which the patient is, not the jurisdiction in which they're in. And they need not just good intensive care skills, but also skills to use whatever technology may be needed. And I think also it's recognized that having staff with debriefing skills and simulation training experience is also very valuable. And certainly some of the things that can be happening at the other end of the screen can be very traumatic for those taking part, but also for those watching. So critical instance debriefing, stress counseling is also an important issue. One of the crucial things as well is the medical legal issues. So not just making sure that staff are appropriately trained with adequate recognition and registration of their qualifications, but concerns with patient privacy and confidentiality, making sure that documentation is appropriate. And as I've said, I think often, mobile phones and casual calls are made to doctors in metropolitan centres from regional areas. And there's not the same process with adequate documentation, closing the loop on communication. And very often patient-sensitive data is sent via social media or non-secure carriage systems, which has another range of problems. The piecemeal nature somewhat, for different jurisdictions and different states doing different things, has led to a lack of governance and regulation of the services. Our fellow college, the Australasian College of Emergency Medicine, is in the process of producing a document on definitions and practice standards for telehealth. And this will be reviewed by the Council for the Presidents of Medical Colleges, which combines all the medical specialty colleges in Australia and Aotearoa, New Zealand, with the aim that this will be a document that will be endorsed and disseminated through all the medical colleges. This has been alluded to as well, but I think we have to be aware that for Australia and Aotearoa, New Zealand, adequate resourcing is very important. And that the people with the purse strings may see remote critical care as a cheaper option for providing intensive care resources to regional areas, when actually what is needed is the establishment of a properly funded local physical intensive care service. And I think if that is the case, then we have to be definite that that's what we work for. I will say, though, that particularly sort of for rural areas in Australia, where patients are able to stay in country, this is really important, not just for a financial benefit, but for enabling patients to stay connected with family for their emotional well-being. And in cases where transfer to a bigger centre would actually not change outcome, and the patient is able to die in country, that is something that has great cultural significance. So that is a very important consideration. However, I think we also need to have staff who are quick to recognise when a patient does need to be transferred, as the distance we're talking about are considerable, and delay in making that decision and initiating that transfer can actually lead to a worse outcome. I'm going to hand over now to Brad Wybrow. Regrettably, he can't be here in person, but we have his presentation. And Brad, like me, works in intensive care in Charles Gardner Hospital in Perth. Brad is dual trained in intensive care and in emergency medicine, and he is the clinical director for critical care for the Western Australian Country Health Service. And he established the critical care telehealth program at the start of the COVID pandemic. Brad is going to talk to you on critical care over distance using Western Australia as an example. Thank you. I think, Jude, if you can bring up the talk, that would be great.
So thank you for inviting me to talk about our experiences with critical care and telehealth and the distance associated with Western Australia. My name's Brad Wybrow. So I'm an intensivist in Western Australia, based mostly in the metropolitan area, but I've done quite a lot of work with the Country Health Service, and that's really where what I'm going to be talking about today. And hopefully some of you are familiar with Western Australia. We're far away from most places in the world, but we do have quite a large area. So we're 1/3 the size of Australia, 10 times the size of the UK. And most of our population are actually situated around the very small southwest corner of Western Australia, which that's not so much of an issue. What our issues are, how do we deliver the best healthcare to the rest of the people who live in quite far rural and remote areas throughout the rest, particularly the north side of Western Australia. And so this will be a common theme through all the through other speakers, and is that we really want to try and ensure all of our Western Australians have access to good healthcare and really mitigate the problem of distance. And that should really be our guiding principle, that all have access to equal healthcare. And in Western Australia, we have 108 hospitals outside of Perth. And most of them actually don't have an on-site doctor. They're often just, they're quite small. They only have a few nurses on and some inpatients in the hospital itself and an emergency department. We had problems with staff turnover. There's a large locum workforce that fly in and fly out. And so maintaining skills and relations, it's can be quite difficult. And so in that setting, we already had that setting before, and then we had COVID. And that's where sort of I got involved more and sort of recognised, I guess, there were going to be a few issues, particularly like that rural and remote people were going to be more at risk. And so how do we get healthcare and how do we provide oxygen support and things to potentially to a large number of people? And how do we deal with that in the setting that we're likely going to have transport delays, and transferring patients out is going to be very difficult. And so we got together and tried to come up with some goals of what we really wanted to achieve. And at the forefront of that was always going to be patient safety. So we wanted to ensure good clinical care so patients remain safe. But we also wanted to support staff. We recognised they were looking at other places in the world that staff were already stressed and overworked, and how do we provide them support and provide the knowledge that they need. We really wanted to get early goals of care discussions in, so but we'll talk about that. And then we also wanted to provide some education and some upskilling to these sites. And then we also needed to identify what equipment, what sort of resources do we need to improve on, and how do we get that to the sites, and then also the transport logistics and how do we deal with retrieval services. So they were the sort of four main areas that we wanted to focus on. And as with anything, we sort of realised that the most essential thing is that we need good people and we need the infrastructure in place. And so from the infrastructure point of view, we're very lucky in that sort of a few years earlier, the emergency telehealth service had set up throughout the state, which meant that they'd put good quality cameras in every resus bay in the hospitals throughout Western Australia. And so this is one of those resus bays. This is in Mount Magnet, which is a very small town. Usually just has one, sometimes two nurses, a couple of nurses on at a time. And as you can see in the background there, I don't know if you can see that well, but there's a monitor there, just a blood pressure and heart rate monitor there, the Welsh Allen one, and then on the insert, I've zoomed in on it. So that's the same room, same picture, and I've just used the camera at my end to zoom in. So you can see how with these cameras, you can see if a patient's in atrial fibrillation. You can even look at rashes and on skin, and you can, like, the amount of detail and what you can run is really quite sort of amazing. And even running a resus is sometimes easy because you don't have that temptation. You can't touch the patient, so you've got to stand back and provide clear, good communication. And so we found we really need those good sort of communication and good camera and technology at that end. At the doctor end, at the other end, we found sort of flexibility was a lot more important, because the site doesn't have to see you with the same resolution, but what you do want is a workforce that's engaged, that wants to work for you. And when it's busy and there's a few resusces going on at once, that you can put a call out and someone can just grab their laptop and jump on. You know, they might even be on holiday and they can jump on for an hour and help out. And making it really easy and simple to use was the important factor in maintaining a good workforce. We also found the software was useful, or an important factor, in that so with the way that it's set up, is that you can have a few rooms. So you can have a nurse and a doctor on in separate cameras, and the doctor might be giving advice or running something important, and may need to jump off and make some phone calls to arrange some retrieval services or get some advice from another specialist in town. They can, even if the specialist has that capacity, they can even potentially jump in on the call. So having that ability to jump in, and while the nurse might be in there, and be able to institute further plans on their camera and stay with the patient, we found that really useful. And just the ability to sort of keep eyes on the patient while you're doing other things. So that was one important area. Then from the equipment side of things, we had to, I guess, decide about everything almost, that what level of critical care do we get out? More inotropes? Do we get lines out? Do we, and particularly one of the things with COVID was always going to be oxygen. So there is, some of you be aware, there is some comparison of non-invasive ventilation and high flow nasal prong support in COVID, and and there are potential some benefits to non-invasive ventilation for a recovery trial and some other areas, but they're both very good therapies, and the numbers aren't so different. And that when you think about getting a nurse who's never used either in a remote setting, high flow nasal prongs are so much easier. You can watch a 5-minute video and you're probably just as much as good an expert as setting up the circuit. The patients are more comfortable. They can do other things, eat and drink. So in terms of the how intimidating it is to provide that level of support and how much oversight you need, it was really a no-brainer, and we rolled out high flow nasal prongs to a large area of the state. And it's just those decisions about extending care, but at the same time deciding about what is safe and what can be done. Because particularly for things like sedation and analgesia, if someone has traumatic, fractures their femur and it needs to be splintered or reduced, giving some ketamine with some close watching and some support is probably a reasonable thing to be doing. But as opposed to getting that patient intubated for someone who's not intubated before, that's really probably not a safe thing to do. So it does require some thought about what level of care are we going to be able to provide when we're not there on the ground. It's always nice to have a good feel-good story, and so this was a few years ago now, but this was one of the nurses who actually does some work for the Telehealth service, or is the recipient, because he was a nurse in Coral Bay, which is a very small town, sort of a holiday town, probably about 15 hours north drive of Perth, and he had chest pain, had a STEMI, managed to cannulate himself, get on the camera, send his ECG down, and give thrombolysis to himself under supervision, and did well. So, and then got retrieved. So, like, it's always nice to get these stories to sort of validate what you're doing and make everyone feel positive about the work that they're doing. And so then it came to goals of care. We really wanted this to be done well. So we have a really important, valuable, strong Indigenous population in Western Australia, particularly in the northern areas of the state. And it's really, and if they're very sick and likely to die, then they'd rather that happen on their land. And that's, not just unique to them. Like, there's a lot of people would rather die in their home setting with their family around. So there's that, and there's the issue with that, the importance of having someone senior and who knows how to do goals of care discussions with patients, because it's almost worse or makes things worse if it's not done well. So if a junior person just says to the patient, do you want to be resuscitated, and then ticks yes or no, it sort of makes the next discussion a little bit harder. So we really wanted to get people who had experience, who could give some insight into what critical care means and what being transferred away from your home into an intensive care means, and is that really something that you want for you or your loved one. And having these high quality cameras and being able to have those discussions over the camera was very valuable, I think. We did we also use these cameras to do the upskilling and education. So that's me giving a talk down the bottom there, and Steph, one of our other doctors, running some resus, and the top one there. So you can provide education to a large group of people when you've got this sort of set up already. And I mean, the fidelity is somewhat dependent on what resources you have available, but you can always aim high, and you can even with just a simple mannequin, there's some pretty simple computer programs. I'm sure most of you are familiar with this sort of stuff, where you can have the rhythm and the blood pressure and the sats, and you can alter them. And if you've got two people running that, someone in the background altering things and someone else providing the scenario, you can really provide some good sort of very real life simulation where you get buy-in from the sites and provide good education. And some of the things that we did were sort of COVID intubation scenarios, cardiac arrests, and different sort of elements of shock and sepsis. And then one of the last things we did was, we still do, is telehealth ward rounds. So that's sort of providing for an ICU round for the consultant to a high dependency area where they have a few patients who they can care for, and we can maybe just currently we just do that for one site regularly, and we do that once a day in the morning. And the things that work really well is you sort of really need a dedicated person at the other end. It wouldn't have to be a doctor, but having multiple teams come in for different patients at different, getting everyone there at the same time would be difficult. And also you want someone to take overall governance, who's going to follow up on the plans or the advice that you sort of come up with, and feedback and liaise with you. So that's what I think is really needed if you're going to run sort of telehealth sort of ward rounds. But there's certainly a very valuable and well-received support to sites that that are lacking that support. And so the future for us, I think the stuff is that we'll probably use the telehealth capabilities more, maybe for more standard referrals, because there's a lot of indirect cues and benefits you get from just getting eyes on to the patient, and that you don't get from just a simple phone call. And then I think the challenge as well is finding out how to evaluate outcomes. We've certainly surveyed nursing and medical staff, and a little bit with patients as well, and they certainly feel the benefit is there. But in terms of finding hard outcomes, certainly you can look at patient transfers, but we've found that some transfers increase and some decrease, and we feel that we're doing more appropriate transfers, but getting that, finding out those hard outcomes and patient orientated outcomes, I think is a challenge that needs some work on for evaluating the outcomes of telehealth. So that's about it, I think, from us in Western Australia. Enjoy the rest of the conference. If you've got any problems or sort of questions about our setting or anything else you want to just hear from us, that's my email. And thanks again for the opportunity to chat. All right, all the best.
Well, given that Brad wasn't able to be here physically, that was a fantastic talk with lots of us to think about. We are going to have a comfort break because I think we've been going for over 90 minutes. We'll just make it, if we can, just 5 minutes. So just 5 minutes from when we sort of close for a moment. And then we're going to hear from Dr. Sanjay Subramanian from the United States to share their experience. And from that, we'll go straight into our panel discussion to end the session. So just 5 minutes if we can, and we'll see you very soon.
So the system will stay on. So just log in when you come back. Or not log in, sorry, just stay on it. Thank you. So welcome, Ms. Sangeeta. I just saw you briefly. I thought I'll say hello. We will be starting in about 3 minutes time. It's the break time at the moment.
Okay. Good afternoon, and very happy to see all of you on this program. I'm happy to just listen in. Thank you.
So we've got one presentation from United States and then followed by panel discussion. So it'll be good to have you during panel discussion and then concluding remarks from you in the end. Thank you.
Well, my great pleasure to welcome everyone back to the symposium. It's been some great discussions, lots of thinking from all around the world. What we're going to do now is got one more speaker, and then from that we'll go into our panel discussion to really sort of pick out some of the themes we've heard. But we're definitely trying to finish on time as per our schedule. So I'd now like to welcome Dr. Sanjay Subramanian. He's an associate professor in St. Louis Hospital, Washington, and he's really a leader in that hub and spoke model of electronic remote critical care. He's got a keen interest, and he's been a leader in all the digital health solutions that we've been hearing about. So it's our great pleasure to welcome you. I hope it's not too early in the morning for you. Maybe I think it is, but welcome, and we're great to learn from you. Just on mute, Sanjay.
Yeah, thank you. Thank you for the invitation. It's a pleasure to be here, and I hope to share some perspectives from the United States. Just want to share my screen. I hope it's visible to everybody. So can everybody see this screen with the title slide?
Good. Looks good.
Okay, perfect. Yeah. So a quick introduction about myself. I'm an intensivist. I currently work at Washington University in St. Louis, Missouri. I've been involved with telecritical care for more than a decade. I've helped implement some programs, as well as recently been involved with a rather interesting federal government project for telecritical care. And I'll tell you all about it in just a second here. So in terms of learning objectives, I just thought I'd list down what we're going to cover in this talk. And I'm just going to spend just a few minutes talking about traditional tele-ICU systems in the US and how they have sort of evolved, as well as sort of just list out very high level about the evidence around telecritical care / tele-ICU. And then really a lot of the talk, we're going to talk about a specific type of COVID response that I was involved with, which I think has a lot of future potential as well for an all hazards approach. And then, of course, talk a little bit about some of the barriers we experienced in the future direction for telecritical care. So as many of you might know, tele-ICU has been in existence for almost more than 2 decades now in the United States. And it was started originally as what they call the EICU, but we've sort of gone away from the term and used the word tele-ICU or telecritical care to sort of define the notion of critical care outside the confines of a physical intensive care unit using telemedicine technology. The legacy systems, that were developed over 2 decades ago consisted of fixed point-to-point communication structures with dependency on hardwired patient rooms with cameras. And it came at a fairly expensive price tag. It was what we call, as you mentioned, the hub and spoke model or the bunker model, where you had co-located staff, physicians and nurses within a room with the ability to camera into patient rooms and provide on demand or more proactive patient care. However, over the last 10 years, as we all know, there's been rapid development of newer technology, mobile technology, and cloud architecture has really taken over all technology platforms. And the same has sort of happened, although at a much slower pace in tele-ICU as well. We have noticed in general a shift from the hub and spoke model or the centralized bunker model to a more of a decentralized model of tele-ICU in the United States. And we now use the word telecritical care as sort of the ubiquitous word to describe the support and provision of critical care support to patients, not just in ICUs, but any location, could be even at home, could be in the intensive care units, emergency rooms, etc. So just a quick word again about the legacy tele-ICU systems. As we mentioned, they were in central bunkers with staff, and it was all hardwired camera installations. It was pretty much a non-cloud based system, and these are still actually commonplace in the United States, especially large academic centers where they have affiliated sister hospitals or hospitals within healthcare systems that are networked into a central bunker through which care is provided. However, even this has sort of gradually been modified to have sort of multiple hubs, if you will, and a sort of a more distributed approach to staffing as well. And staff may not always be located within the same location as well, as long as they're connected to each other through the same network. The legacy systems typically have multiple systems in place for the physicians or nurses for documentation, internal communication, and for workload assignments. So the picture on the right is sort of a typical traditional EICU room that you see with a physician who has, typically multiple screens, one to look at, for example, the vital signs on a patient, one to look at the patient record, one to communicate with the patient rooms, and there's one more screen often for receiving messages and text communication. So a little bit of a patchwork of systems, if you will, but that has been the model that has existed in the US for a number of years. Now, just to talk about tele-ICU in general, in terms of the evidence around this care delivery model, as I mentioned, it's been there for 20 years, and there's been a number of publications around it about the impact on mortality, benefit, length of stay, and other ICU metrics. The problem with a lot of the evidence, of course, has been that there have been very few studies with rigorous methodology. Really no prospective randomized cross trials with crossovers, and most were, as you know, pre and post implementation studies or observational studies. It's always been difficult from these studies to make causality inferences versus just attribute the benefits to association. Part of the problem is that there's been a lot of variability and heterogeneity in the tele-ICU models used in the United States in terms of both the staffing and the structure. There are centers where physicians are heavily involved in the day-to-day management of every patient compared to other tele-ICU systems where the physicians are more responding ad hoc or on demand to questions or situations from the ICUs. So that has again created issues with how to interpret the best evidence. And also, as I mentioned, the way it's implemented is rather heterogeneous, and the level of engagement of the remote physicians and the remote staff with the actual bedside clinicians and the bedside system has been quite variable. So all these things have contributed to somewhat of a lack of conclusive evidence around the benefits of tele-ICU per se. But I think the overarching theme is that it does provide a way to augment staffing. It does play an important role for supporting bedside clinicians with the scarce resources, and I think fast forward to 2020 with COVID, it sort of was an inflection point, and really tele-ICU adoption just pretty much skyrocketed in the United States with rapid adoption of different types of tele-ICU technologies and leveraging existing tele-ICU systems to provide care to COVID patients. So, the adoption up until 2020 was somewhat slow because of the lack of uniform evidence and the cost associated with it. But I think with COVID, there's been a lot of innovation around more nimble, agile staffing models and low-cost care delivery models. And I'll talk to you a little bit more about one of those. So, COVID has really demonstrated the need or the case for rapidly deployable technology response to disasters. I mean, COVID really exposed the fragile nature of the US healthcare system. And the COVID response really demonstrated the need for skilled care providers and resources to support healthcare systems in both urban and rural areas, where obviously we have the same issues that other countries do with not having adequate resources across large segments of America, which are fairly rural and not urban in nature. As we all recognize, telemedicine can be a force multiplier. The technology enables expertise to be leveraged widely across large geographic areas. Pandemics, obviously, they require agile solutions that can be rapidly scaled. They're not expensive, and they don't have to necessarily always rely on extensive hardware installations. And as we all know, globally, or definitely in the United States, the critical care workforce distribution is highly skewed and maldistributed, with most of them practicing only in large urban centers. And just the total number of critical care clinicians continues to be a scarce commodity. If you look at, broadly speaking, if you look at technology in disaster environments, there's sort of three broad areas where I think this is applicable. The idea of virtual clinics, where you shift the location of patient evaluation from a clinic to actually the patient home, is one. And using mobile health technology, virtual clinics can help flatten the curve of a pandemic, for example, by moving evaluation to the actual patient location in their homes. And I've just given some examples for some existing solutions that do this. Now, virtual hospitals is sort of an extension of a virtual clinic, and essentially the idea is to put telecommunication technology in place to provide support to many distributed patients to from one or many locations. And then this is sort of basically the tele-ICU or the e-ICU that has been existing, but the idea is that your remote experts would be able to provide support to less qualified caregivers. Like in a lot of hospitals in the United States, ICUs are staffed by non-intensivists or hospitalists. So especially during COVID, for example, these hospitals had to deal with the burden of a large number of COVID patients who were very critically ill on ventilators, on non-invasive ventilation, et cetera. And that was definitely outside their comfort zone or in scope of practice. An extension of virtual hospitals is actually, and this is somewhat largely experimental, is the idea of using technology for remote control of ventilators, remote control of IV pumps, et cetera, which can further increase your capacity. And this is an area that's, I think, of huge interest to me personally, and I think it's just be very interesting to see how this all evolves. The third sort of component of how technology can be used in an all hazards environment or disaster environment is to use dashboards that aggregate data from a local, regional to a national level. And this data aggregates data from multiple data sources besides patient records, including mobile devices, wearable devices, IoT platforms, et cetera. And then on a backbone of this, as we build in artificial intelligence, algorithms, it provides, leaders in charge of pandemic responses, for example, with actionable intelligence. And there's actually, there's a pretty important area that's growing, and there's companies that, specialize in massaging large volumes of healthcare data. So again, this is just a graphic representation of how the technology can be used in various forms for supporting response to pandemics and disasters. This is just a sort of a graphic example of, how we can create dashboards for situational awareness and decision support, for status monitoring and predictive analytics. And the idea is that, both high density and low density regions can actually support each other as long as you have access to the same information. And this is just a graphic representation of the same, of how on the left side, you see low density regions supporting high density regions. When I say density, it means density of population, density of cases. And the right side is vice versa, the reverse. In fact, this is what we actually saw in the COVID pandemic, which is initially it broke out on the coastal regions of the U.S. with the large population centers, subsequently shifting inwards to primarily to large parts of rural America and then less populated states. So now I just want to sort of pivot to the major portion of the talk, which is the nets and systems. So, you know, given that background with problems with legacy systems in terms of the structure, the technology investment, the cost, and what we saw unfolded with the COVID pandemic, the United States government actually decided that there was a need for something different, something that was more comprehensive, mobile friendly, and scalable in terms of telemedicine, a disaster response system to provide urgently needed expert support. I would say expert in terms of critical care, intensivist support during the COVID pandemic. The idea was that there would be a nationwide network of intensivists and other specialists to provide immediate consultative support. And this would be completely going away from the hub and spoke model and really more of a decentralized model that allows optimum matching of supply and demand, and really to use cloud-based technology that was cost effective. And obviously such a technology, given COVID, the nature of COVID and the rapid spread, it had to be implemented rapidly, needed to be device agnostic with minimal hardware requirements. So it began as lasted over 2.5 years and was led by the Telemedicine and Technology Research Center, which actually falls under the Department of Defense. And the project has since moved on to ASPR, as we call it, which falls under the Department of Health and Human Services, but the government, but essentially it was a federal program. And broadly speaking, the requirements for telemedicine capability for this nets and system were very broad, and it sort of envisioned a telecritical care network that had its footprint across multiple locations, no matter patients in senior living centers, at home, to provide point of injury care, and also even existing telemedicine or telecritical care systems is to extend bring those in to the network as well, to sort of have a much more broader coverage of hospitals and health systems, using hospitals or health systems and patients outside hospitals for telecritical care. And the idea was that this would there would be a national regional command centers that allowed the federal government to look at data across these different centers providing telecritical care. And this was all, as I mentioned, to be completely cloud-based technology. And again, that this is a little bit more of a involved graphic, but it again talks about the data requirements and capabilities of the nets and system in terms of taking a single level patient data, aggregating that across multiple patients to create situational awareness and operational data for each care location, and also to use in real time the patient ratios and staffing loads to make informed decisions about optimizing the matching of the resources to the demand. In terms of the next slide again shows a little bit of an extension of the previous, in that for this particular program, there was also a parallel research arm into exploring more novel data sources, which is using, for example, mobile devices and other sources of data, and see how that could be aggregated at a large level and create population-based tools for early interventions and actions, and to provide analytics with AI for intelligent displays to provide actionable information at both a regional and a national level. And this was not data just from medical records, but also data from mobile devices as well as, and this is an ongoing sort of a research component of this program as well. So again, just to reinforce, this system was intended to be a distributed care provider network model supported by multiple teams of physicians, nurses, and actually a multi-vendor system of systems approach. And then the technical infrastructure for this system was such that it should facilitate the use of multiple telemedicine technologies to deliver capabilities for scheduling, for control documentation, intelligent assistance, etc. And in parallel, there was a component of development or further development of semi-autonomous and fully autonomous systems as well. This is somewhat of a repetition here, but I just wanted to just highlight the fact that, again, there were various components that were used to create the NetSyn system architecture, but not all were uniformly utilized for provision of care delivery, but the high-level vision was to have a mobile telecritical care platform, medical IoT platforms, an open patient data API with a master patient index and a data repository that's based on open standards and a data dictionary. So the idea was to integrate all these components to form an end-to-end comprehensive nationwide care delivery system for telecritical care. Just a quick a slide about the timeline of how this project unfolded. So it was launched soon after the COVID pandemic. It was launched as a RFP, or actually an RPP, by the US government, and it was a competitive down selection process. But unlike other government projects, it was a relatively, I say relatively because it was still a somewhat of a slow rollout, but considering the government, it was fairly rapid. There was a phase 1 and subsequently a longer phase 2. And the phase 1 involved rapid sprints with defined deliverables. The government tasked the performers, as they called them, or the vendors who were selected for this project to develop MVPs and subsequently roll out fairly quickly support to hospitals in multiple states of the United States. And then the same work was continued through the second phase with where additional functionality was developed within the platform and additional cybersecurity measures were implemented. So in terms of just the different players that were involved, so I was involved with the implementation team of this program as part of the telemedicine company, which is Omnicure, that provided sort of the backbone of the telemedicine or telecritical care technology solution to provide the actual critical care support. But then this was done in partnership with other companies such as DocBox, which provided a medical IoT platform for data. In addition, we had simulation work that was done at Harvard at the MD PNP lab at Mass General Hospital. And then the Society of Critical Care Medicine provided access to resources or physician resources, as well as using their presence to promote awareness of the program. And they continue to be involved in trying to use the data from this project for research and publications. So high-level system architecture of how this system works is, that there's the backbone or the cloud-based telecritical care platform, and you have patients on one side and data from patients either through medical records or in the most austere environment, it is actually just manual input of patient vital signs and basic patient data coming in. And then this is all visible to the remote physicians who could be located really anywhere within the country to provide on-demand support primarily. And then the platform capabilities included the standard telemedicine capabilities, which is messaging, synchronous, asynchronous, audio-video calls, features to simultaneously activate physicians in times of emergencies, which is what we call the SOS feature, as well as a capability to bring in additional physiologic data through EMR integration, medical device data, and then obviously a need to visualize high-level system metrics and operational metrics through a system dashboard. So this just lists all the sort of the capabilities of the telecritical care component of the NetSyn platform that was necessary for provision of care. I'm not going to go into the details of each of those, but really there was a multiple capabilities that were utilized. I will flag the fact that the system had built in some severity of illness indicators. We used a new score, which was chosen because it relies only on vital signs to flag patient severity of index, and B, it has been validated by studies as well, I believe in the UK primarily, and the new score helped inform the remote clinicians about how sick a patient was. Now, in many instances, we only had access to basic vital signs, or one set of vital signs that actually were manually input into the platform, and so the new score was calculated off of just that basic initial set of vital signs. So in terms of, I have the slide here just to illustrate the fact that this was a mobile-first approach. So there was no hardware installations at any of the facilities. It was all completely mobile device-based. Although there's a capability for using the telecritical care platform on a desktop, but it was primarily mobile-based. On the receiving end, often it was just use of cell phones or iPads that the staff utilized for connecting with remote clinicians. And then the mobile platform was organized in such a way as to allow access to a patient's census at every location, basic clinical data, and had inbuilt team communication tools to allow the care providers to communicate with each other. The other additional features that were part of the system, if you will, was the ability to sort of do real-time load balancing and shift work from certain providers who were overwhelmed on the remote side to others that had more capacity. But the way the system was implemented was completely decentralized, almost, if you will. You can call it an, if you will, an Uber model, if you will, because of the completely distributed nature. All the care communication logs and documentation that occurred only within the telecritical care platform itself. There was no access to the medical record in 100% of the cases. And however, all the information that was captured as part of the telecritical care or tele-ICU encounters was uploaded to hospital systems, EMRs, through a file, not a FHIR interface, but actually we just did an SFTP file transfer process. So the idea here is that you are creating a completely mobile health record that is being utilized for pandemic response, and then it is intended to seamlessly integrate with the actual care record of a patient within a hospital. Within the platform, additional tools were built in for shift management and patient handoffs as well. So in terms of how the platform was utilized, there really were multiple use cases, if you will. I'm just going to highlight the fact that the system was utilized, in many cases for the remote intensivist to provide expert clinician guidance to nurses and hospitalists at multiple small and medium and small and larger hospitals in the United States. Really, it was a way to optimize specialist resources for health systems. In addition, there was a smaller pilot project embedded within the NETSIN program where remote critical care experts provided support for EMS teams within the city of St. Louis. Additionally, of course, the telecritical care platform provided a way for communicating with patients' family members, which was ever so important in the setting of COVID. I mentioned that there was a need for a central way to look at patient at data across the entire system, and so the system itself has an integrated virtual command center that in real time allows you to look at the operational metrics of the entire system, i.e. in real time one would know how many patients are actually currently being evaluated in the system, how many providers or how many clinicians are in the system, what is the average response times in real time per case, per clinician, and then the geographic distribution of the different consults that are requested, or different patients that are in the system across different locations of the United States. So this was visible and available readily to people who are monitoring the system as well. So we call it the Virtual Command Center. It's basically a real-time analytics platform. Just to give you a quick overview of the actual implementation, the nuts and bolts of how actually this was implemented. So it was as simple as bedside clinicians were just given the app to download onto their smartphones. As I mentioned, the wards had iPads or tablets with the application, or when I say app, it's a TCC application or telecritical application downloaded on a device. They created accounts themselves, just signed themselves up. And in real time, those accounts were authenticated by the system administrators. That's it. And then the bedside clinicians just had to enter a request for support, and entered basic patient information like chief complaint and some basic vital signs. If we had the luxury of interfacing with data systems on site and with the medical record, then additionally that data was also visible to remote clinicians. And then subsequently, all communications occurred through through synchronous audio-video communication, and often through text messages as well with the remote specialists. In many instances, when you did not have access to the medical record system, data was physicians often took screenshots of lab work and from the record and shared that with the remote physicians. So just to give you a high level of how this system deployed, the Omnicure and Netson, which is the platform that was utilized, provided support to multiple hospitals. This was actually just over a few months towards the end of last year. This just data from that period. Was about 35 hospitals. Many of them were smaller rural hospitals. And it was across 9 states and 1 U.S. territory, which is the Mariana Islands. I've highlighted some of these hospitals only to show the spectrum. For example, North Kansas City Hospital is a large tertiary care hospital with over 500 beds and 40 ICU beds. On the other hand, Kootenai Health System in Idaho is a smaller system with just critical access hospitals. Interestingly, we actually deployed the solution across the entire state of Vermont, here in the Northeast, to almost 100% of their critical access hospitals in one go. So this was core. It was a statewide effort coordinated through the State Hospital Medical Association to give them access to this system during the COVID pandemic.
Sorry to interrupt, Sanjay. I think in interest of time, if you could conclude soon, please. Thank you.
Sure. Yeah, I just have a few more slides just to talk about the summary data from the Netson deployments, just to show that majority of the support was requested for COVID cases, and the acuity of the patients was fairly high across the board. I would like to highlight the fact that the average clinician response times were, within minutes to respond, and that is the beauty of a decentralized system, and you have a distributed network of multiple providers who are available to provide support. So some of the lessons we learned, this is one of the last 2 slides, is the fact that a simple and similar technology and similar workflows can work effectively for both large hospitals as well as smaller critical access hospitals. However, there are barriers, especially in the United States, with lack of cross-state licensing and a streamlined process for credentialing. There are barriers that can delay implementation of such a system to provide support that's needed quickly in the face of a pandemic or a disaster. And then in general, I would just say that, the barriers to tele-ICU scalability are, broadly regulatory, which I think is a significant problem in the United States. Technology barriers continue to be a barrier to scaling this technology. As we had mentioned, we need reliable connectivity, and that can be a problem in some parts of the United States as well, the more rural parts where there's reliance on existing hardware systems. And then, of course, there are financial barriers, which is how do you fund such a program and how do you make it sustainable? And what is the optimal financial model for such a system to function longer term? Interoperability continues to be a challenge in the United States with multiple vendors and lack of open standards and free data sharing across health systems. But I think the future state involves what we call an ICE environment, which is an integrated clinical environment, where essentially I think the future is going to involve a distributed and scalable IoT platform that connects to any medical device, including sensors, ventilators, et cetera. Additionally, collects data from bedside monitors, from electronic health record system, and really communicates all this data to a virtual cloud data space that allows data to flow to multiple, telecritical care applications simultaneously. And then this data can be used for regional and national reporting dashboards as well, with the vision that multiple telecritical care sites with different vendors can help provide care to the same patients, both simultaneously and asynchronously. So just conclusions here. I think tele-ICU is now, I think it's pretty much a proven tool to leverage scarce ICU staffing resources. Technology advancements have led to a lot of innovation and nimble, cost-effective, scalable, agile systems. And we have demonstrated that, clearly the hub and spoke model is not necessary for providing telecritical care, and decentralized care models are very viable. And there's barriers on the administrative side to adoption and large-scale adoption of telecritical care. And I think telecritical care does offer many opportunities for cross-continental collaboration. And that's it. Thank you.
Fantastic. Well, that's just a masterclass in all that's happening in the USA, but we've also heard a masterclass from Australia, New Zealand, as well as our colleagues and friends in India. So it's been a sort of a great session. We're running quite a bit behind time, and we do want to finish as we promised because we know how many commitments people have. Really, I just want to welcome two people who haven't actually had a chance to speak yet, and that's Professor Ravi Mahajan. He's been an inspiration and drive for this symposium, and he's the Director of Critical Care Integration and Transformation at the Apollo Hospitals in India, and actually the past president of the Royal College of Anaesthesia in the UK, and a friend and colleague of mine from Nottingham. And also to welcome Professor Mike Grocott, who's a Professor of Anaesthesia and Critical Care at the University of Southampton in the United Kingdom, and actually is a keen researcher and is a senior investigator for the National Institute for Health Care and Research in the UK. We're just going to have just a few little questions, and then we're going to be closing out today, and I'll introduce that speaker, Dr. Reddy, who's going to close us in a moment. But really, I'd like to go straight to Mike. Mike, we heard right at the beginning that geography is history. I just want to know what you think about that comment and how it fits with everything you've listened to over the last nearly two and a bit hours.
Thank you, Dale. I guess that I as an expression of direction of travel, I think that's it's a wonderful meme, if you like, to share. I don't think geography is entirely history. I'm at home. I've got to drive to work, which is 40 minutes away after this to do a different kind of work. But I think in terms of the delivery of care, I mean, I've learned a lot this morning. I think there's been some really interesting ideas presented from around the world. I think particularly for whether remoter areas, this is great for patients, because we've certainly from my perspective, we've tended to center on ourselves, so the providers and their convenience, and of course if patients are sick, they need to come to us. We'll just fly them in, as opposed to how can we keep patients closer to where they are by the application of different technologies, and if we can do that and provide care that is of similar quality to that which we offer in the big center, I think that's great. And I think that in terms of patient well-being and being able to be have their nearest and dearest nearby, I think that's very important. I think there's some interesting challenges. I mean, Sanjay mentioned towards the end of his talk the issue of interoperability. It seems tragic. We've got this great opportunity to apply technology, but when the technology won't talk to itself, they won't interact with each other. That's that's a challenge. And I think there are significant challenges and opportunities in understanding how we, both as providers and patients, interact with that technology. So as a researcher, I look at it less as about basic mechanisms of pathophysiology, but some really interesting and impactful questions around the interaction of technology with humans, both the providers and the patients, and all that goes with having trusted and trustworthy systems as part of that. So I think it's been a really fascinating webinar, morning, afternoon, evening, wherever you are, and hopefully agenda setting in terms of the role of the centre, the Apollo Centre, and in terms of this field. So thank you very much for having me along. It's been really interesting to listen.
No, thank you, Mike. We're not going to be able to go through some of the questions that were in the chat, but there was one from Prem Anand, and he asked the question is, how comfortable are the ICU intensivists on automated alerts for remote management of critical patients? Like, here I am working and I'm doing a good job, and then beep, 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 the police person's checking up on me saying I'm not looking at something. I think this is worth asking, because this fits with Jack's status quo. I'm going to go, actually, could we have one of our Indian speakers, either Sai or Ramakrishnan, just to answer an Indian perspective? Then we'll go to Australia, New Zealand, and the UK.
Sure. Really quick, Dale, in the interest of time, we already used this in a setting of a physical ICU. You do have alarms beeping all the time, and if there's a slide I have where I show that the most worn out button on the monitor is the silence button. It's almost wearing off because you're hitting the silence all the time. So I think one of the issues is to try to adjust the alarms, and the technology is technology. So I think we need to set the alarm ranges so that they make sense. I do think that they help a lot. I have worked in an ICU where the AI system actually picked up an early warning score, generates a trigger to the rapid response nurse who goes to the bedside, and the AI system puts a note in the chart saying, this was the early warning score, I alerted the RRT, and the people have been saved that way. So I think the alarm systems, automated alerts, are helpful.
Excellent. Any other thing you want to add to that, Dr. Najarajan?
No, I agree. I mean, it's all garbage in, garbage out. So if we really are able to get good, useful information and build in mechanisms of artificial intelligence where we could get appropriate alerts, then obviously they are very useful. But if it's going to alert for everything, then it's obviously going to delay care and also not be appropriate.
No. Mary, from an Australian New Zealand perspective, we heard from Brad, with the ability to actually zoom in on the different devices and things. And what do you think about the status quo element of that?
Well, interestingly, one of the other hospitals in Perth, Royal Perth, they have a system called Hive, which is healthcare in a virtual environment. And this is more for sort of ward-based care, one step below rapid response, I suppose, but patients who are considered at risk are able to be monitored with cameras, hook up with all their vital signs, and that is monitored on a separate floor with all the kind of technology and cameras, and that's monitored by a group of trained healthcare professionals, I think mostly nursing staff, but with some medical input as well. And then if there's any alerts, they can actually check in with the patient and say, how are you going? How are you feeling? They can alert nursing or medical staff on the floor to go and see to that patient, or they can trigger a rapid response team as well. So that is just in the one hospital in our centre, in our city, but that is using a lot of those strategies that have, sorry, losing my voice, those strategies that we've discussed.
No, excellent. And just quickly to the UK, to either Danny or Jack, we run a hub and spoke model sometimes with our networks of critical cares. Do you think sort of bringing technology to that, do you think that's actually the direction we should really emphasize? Maybe just to Danny, get one perspective.
Just quickly, I would say that one of the things that I think about this is that there's a lot of focus on the human factors element of it, and people have done a lot of human factors research about alarms. But for us within the UK, we've got a strong governance element around this. And I think the kind of the governance element of responsibility and accountability hasn't been thought through to the same extent, because obviously when you have electronic alerts, it's a different perspective in terms of where accountability lies. So I think we need to build governance into that from the UK. I don't know if Jack wants to say anything else.
Well, I think from my point of view, the networks the COVID has really made networks work much better. So for example, locally, we have every morning, there's a phone call, covers all the critical care units in Wales, and that identifies where the resources are, what bed capacities, patient movements. So those broad level things are there. COVID has really highlighted that, and they can get a lot better. I think there's a big issue that, this is a multinational call. There are big cultural differences. I think in the UK, a big issue at the moment is conflict between what we can do in medicine and what the patient wants and what the family wants. And COVID has really highlighted that as well, that patients and families' expectations often aren't, we can't meet those expectations actually. So they have their expectations. We think we know what we can and can't deliver. That would be very different in India, where it may be that if the family has the resources, or in the States and they have the resources, they may wish to pay for it, and that's perfectly within their rights. Well, that's not the same in the UK, and in Australia and New Zealand. There's a sort of hybrid there, isn't there? So there are big cultural differences, but there are definitely things that we can work on together to take this forward. Thank you.
Thank you, Jack. Well, Ravi, we've heard an awful lot, and when we started talking about this, it's exceeded my expectations. Any final thoughts? What are the next steps? And then we'll close off with our guest to close the session.
Thank you. I think I've learned a lot this morning, but then you come to think about it. If you sit back, the themes are very similar, and there are some, if we look at, as Jack's mentioned, there are cultural differences, but if we focus on commonalities, then there is a lot of work to do. And I think the commonality is one of the commonalities is the realization of the fact that this can be a solution for lots of different problems that different countries are facing in the future. Also recognizing that there are bits that need to be done, and that could be in the form of training, in the form of producing guidance which makes sense, in terms of regulation, in terms of policy, setting standards, which require all of these. If we are to work or to boundary bust, Mike would know that term I've used so many times in the college. We've got to be boundary busting as the leaders of profession, and looking at going beyond these geographical boundaries and looking at common solutions. And when we do that, I think those are the areas where I look, where different organizations and different leaders, as present here today, this morning, can work together on. Thank you.
Thank you very much, Ravi. And boundary busting, a lovely bit of alliteration to finish with. But just to formally close, could I just welcome Dr. Sangeeta Reddy, who's the Joint Managing Director of Apollo Hospitals. She's got a keen interest in digital enhancement in healthcare and tele-ICU, and has been very patient. And thank you for joining us and for finishing this session. Just on mute.
Sorry. So namaste, good morning, good afternoon, good evening. It's such a pleasure to hear all of you. And let me begin by saying that the collaboration, the depth of ideas, the commitment to the use of technology to create an improved future and an improved care environment are truly inspiring. I think that it is no longer in debate whether technology is going to assist us. The only question is how much, when, where, and how fast. So having, we have access to global patients, we understand what's happening in telehealth across the world. And the only thing I can say is that it's just getting better and better every day. I don't want to reiterate everything, so many of the points that all of you made, but I just want to thank you for taking your time to come and speak. I want to appreciate the thought process. And I want to add just one dimension, which I think was briefly mentioned, but is probably one of the critical drivers. And that is the workforce shortage on one hand, and the exhaustion and tiredness of the healthcare workforce as well. And I believe that if we can get this solutioning right, if we can appropriately embed it, so the alarms are truly alarms. You are proactively alarming if someone is going into sepsis because you've analyzed 20,000 records and you understand the confluence. So the alarm is no longer just a monitor beeping on one side and a separate infusion pump beeping on the other. It is the combination that you brought together with IoT, with AI, and with clinical actionable insights. If we equip our healthcare workforce with this, can we reduce their exhaustion, improve the care that we give our people, so that I truly visualize that we get far higher productivity and often time to just empathize, because you're not running from task, but really seeing the whole picture. But I believe the future is bright, especially with leaders like all of you. It's been inspiring listening to you. And on behalf of Polo, I want to thank every single one of you, with a special thanks to Dr. Mahajan for everything he's done to transform critical care in this part of the world. I look forward to meeting you, to working with all of you, and to working together to help establish these global standards, so that if any part in the world needs us, imagine we're all ready to help Croatia. Can we send a solution? Can we send and sit in our own homes and yet contribute? Because I know it's burning everybody that we're feeling so helpless about what's happening. Can we change the dynamic of the power of care? So there is so many inspirational things about this confluence of medical science and technology that it leaves us just breathless with the amount of things we need to do. So I wish you all the very best, and look forward to meeting you personally sometime in the future. Thank you and namaste.
Thank you, Dr. Reddy. Well, that brings us to our conclusion. And on behalf of the Apollo Centre of Excellence in Critical Care, the College of Intensive Care Medicine of Australia and New Zealand, and the Faculty of Intensive Care Medicine in the UK, thank you for joining us. Good morning, good evening, and good night.